I'm going to start if it's good.
Sure, sir. Please go ahead, sir.
Yeah. Good evening to all our friends who have joined this meeting today. We know that we're bombarded with a lot of online meetings every day, but you do not get speakers who are presenting content which is their own hard work, their own learning on the journey, and futuristic as well. Myself and Srinivas have both been great friends, brothers, for a very, very long journey from year 2000. But what is more amazing is we used to call him as Lightning Srinivas because he used to get ideas, solve problems in no time. If I were to count some of the major contributions that he has done, I think he's the first person who believed in extubating babies at lower pressures or better pressures than we used to initially. That means early extubations. Worked on indigenous CPAPs in India when we did not have full-time CPAPs. Worked on early versus not so early surfactant, various prongs. Then now even developed his own CPAP machine, which can provide you both FiO2 and control of humidification. And it is his own patented product. Srinivas has probably 100 of publications and given podium presentations at prestigious meetings across the world. And this is only his work in RDS, not to speak of his work in quality improvement, neonatal jaundice, sepsis prevention and control, and a lot of work in making the CPG guidelines, which we all read today. Over to you, Srinivas. I think we are going to have an enjoyable evening with you. Thank you so much.
Thank you, Naveen, and thank you for those kind words. Yeah, we all belong to the same generation, one generation before the present neonatology group, and we enjoy doing neonatology and we enjoy our work, and that's why we are able to show some results, what we have been showing for the last 20 years. Yes, neonatology is a developing field, and we ourselves have seen how neonatology has changed over the last 2 decades. I remember Naveen and myself doing residency in PGI, and then there was a time when we would intubate the baby, give surfactant, and surfactant used to be smuggled. If you remember, Naveen, we used to get surfactant at 25,000 those days. In 2000, 25,000 used a huge money, and but still we use surfactant, and it was a artificial surfactant which we have used. We didn't know how to use CPAP in our MD days, but when we came to DN, we started using CPAP. Yeah, time has evolved. Now we can safely say that most babies more than 28 weeks, more than 1 kg can go home safely with a good heart and a good brain, and also good long-term outcomes. And thanks to technology, thanks to the work of all our esteemed seniors, our faculty, colleagues, and also the young generation who are bubbling with knowledge and skill. And we are thankful because many people have opted for neonatology, and definitely myself and Naveen can feel good that our next generation is also going to take good care of the babies. And we have seen neonatal units developing across the country. They're going to towns and villages, and every baby is now given importance as much as the baby in the metros. So with this background, I will work on the topic for today, and that is on RDS. So when Naveen asked me to talk on RDS, I felt really good because this is one area which is like the neonatology. So you can speak about entire neonatology and still say you spoke about RDS, because neonatology is RDS and RDS is neonatology. And however, today I will be talking mostly on advances in the management of RDS, and I will try to do justice and covering most of the areas related to this topic. And I will also see what is the futuristic of this particular topic. Disclaimer, I am innovator of Merck's Precision Air Oxygen device, and I will be showing this device during my presentation because it is going to help babies with RDS. And it's a T-piece with inbuilt compressor and a blender, and it displays FiO2 pressures, and it can be used as a CPAP device when combined with a humidifier. So the objectives of this presentation are to tell you the history of RDS world over and to touch the recent advances which are related to prenatal management, birth management, golden hour management, and postnatal management of respiratory distress syndrome. And how do we prevent RDS going to BPD? So we all know that many of the small babies, especially those less than 28 and less than 1 kg babies, many of them land up with bronchopulmonary dysplasia. So our efforts in the initial phases are the ones which will prevent us going RDS to BPD. So this is the story of RDS, and in 1953, this disease was labeled as hyaline membrane disease, and all of us know that babies who died with this problem, when they did the sections or they cut off lungs, they found that there was a hyaline membrane along the lungs, alveoli of the lung, and that's why it was known to be as hyaline membrane disease. Now later it was converted from in 1960s when we came to know that this is because of surfactant deficiency, HMD was labeled as RDS. So the term hyaline membrane disease no more used because that is a autopsy diagnosis. Now we know that respiratory distress syndrome is a diagnosis of this condition, which we are talking today. The impetus for this diagnosis came, or for prematurity or for neonatology came into picture with the birth of President Kennedy, USA president, who was born in 1963. He was born at 34 weeks, 2 kg. And this baby born at 34 weeks and 2 kg died of RDS. And that is when people realized that this is a preventable and a treatable cause. And a lot of impetus came in during that time. And then subsequently, you can see how things have changed. So I don't think now we can think of a death of a RDS baby of 34 weeks and 2 kg dying because of RDS. And I'm sure that everywhere in the country, we can manage such babies very efficiently and then also give a good outcome for all these babies. But look at the story. 1960 to 1990s, world over, it was only ventilation. So if the baby has RDS, the baby was intubated, ventilated, and then baby should have come out of ventilation 48 to 72 hours. He will be on ventilator because the lung used to take about 48 to 72 hours without surfactant to improve. And diuresis was an important method to say that baby is improving. As the lung inflated, the atrial natriuretic peptide increased and then diuresis started. So onset of diuresis used to be an indicator for the lung baby has improved from RDS. So only in 1987, when the Colombian experience was published, and that is when we realized that CPAP should be the primary therapy, because in Colombia, they were using CPAP and rest of the world, they were using only ventilation for RDS. And this experience published in 1987 came to limelight, and then everybody realized that you can do better job with CPAP rather than with RDS. And then came the story of CPAP taking over, and most of the babies of more than 28 and more than 1 kg babies are no more ventilated. They're all kept on CPAP for management of RDS. And the similar time, it was antenatal steroids for prevention of RDS have come into picture. And remember, one of our colleagues, Dr. Sandesh Kiran, has worked on giving antenatal steroid repeated courses. That was a time when steroids came into picture. And it was in 1905 to 2000, that time, when we worked on antenatal steroids, repeated courses. And Sandesh did that work, wonderful work, and shown that repeated courses of steroids do not have value, whereas one single course is the one which we should all be aiming for between 24 to 34 weeks. And 1990s, this was a time when surfactant came as user for RDS. So it was first CPAP, then first ventilation, then CPAP, then RDS steroids, and then came surfactant. And surfactant came to India only in 2000. So that was a time when surfactant was smuggled into country, and then really surfactant became off-label market, or in the pharmacy it was available only in 2003 and 4. That was a time when the artificial surfactant was available, and again 2000 was the time when intubate, surfactant, extubate technique came into picture. Before that, all babies who are insured or babies requiring surfactant were ventilated. But that was a time when the combination of CPAP and insure came into picture. And it was the seminal study work by Dr. Barbara Smith that 2006 and 10 caffeine trial came into picture, and caffeine got added to the armamentarium of management of CPAP. Management of RDS. 2010 to 20 is a time when we are seeing improved ventilation. And the whole purpose of this was in babies who are extreme preterms to prevent PPD. So if you're giving CPAP, if you're giving surfactant, if you're giving steroid, many of the time babies out of CPAP. But like extreme preterm babies, many of these babies will continue to require ventilation, and babies who are having RDS, we're going for BPD. And that is a time when volume targeted ventilation, a synchronized mode of ventilation came into picture. And now we know that most of us use volume targeted ventilation for management of RDS if you are ventilating the babies to prevent BPD. And the new words like MESA, LISA, laryngeal mask, we are hearing only for the past 4-5 years. All the work is only 4-5 years. We are talking about this, giving surfactant to minimal invasive techniques or least invasive techniques or laryngeal mask. All this has come only very recently, 4 to 5 years back, or maybe little more than that, but these have come into limelight only for the last 4-5 years. And what is future? Future, I think, you will be getting very soon the nebulized surfactant, where you put the CPAP and through the CPAP port you can nebulize surfactant. And this is already in the making. I'm sure that very soon you will see artificial surfactant or synthetic surfactant which can be given through nebulized form and CPAP along with CPAP, and your need for ventilation would simultaneously come down. Budesonide with surfactant is already shown some effect, and I'm sure that this is going to add to the armamentarium to prevent BPD. And I'm seeing new work coming up, synchronized NAVA, synchronized NIV. So NAVA is a new method of giving CPAP or non-invasive respiratory support for babies who fail CPAP. We give NIV, and through the nose we can synchronize. So we have found that the NAVA is the best method to synchronize even for non-invasive ventilation. So this is future, and I'm sure most of you will start using nebulized surfactant and NAVA in the future. So I want you to put in the chat box, who are these people? We are shown one on the left, one in the middle, and one in the right. Maybe you can write in the chat box, who are these people whom I'm showing here? Maybe Naveen, you can look at the chat box. I am not able to see the chat box here.
I'll just see if I can. One sec.
Sir, we have few answers here. If you want, I can answer you. Is JF
Yeah.
Kennedy?
Yeah, you can let me know what are the answers.
Okay, sure.
So these are the three people.
To the right, I can come back later, Srinivas.
Yeah, we can come back later. Yes. So I'm sure many of you have already done it. This is John F. Kennedy, the President of America. This is Professor Liggins, who worked on antenatal steroid, and Professor Wong, who is revolutionized CPAP therapy for management of RDS, and he's come from Columbia University, US. So that's all from the history point of view. Then what are the advances which we are looking at RDS management prenatal, at birth, and in the golden hour? Then we'll see how we can prevent BPD. So prenatal advances, two important things which you have to remember is steroids and delivery in a tertiary care facility. Antenatal steroids. So we know that steroids are going to help. Dexamethasone or betamethasone, both are equally efficacious, but Indian government has favored dexamethasone because it's an essential drug which is easily available across the country in almost all the SNCUs. There has been a change in the government guideline so that the ASHA workers can give a IM injection for the mothers who are pregnant, going to deliver between 24 to 34 weeks, and that can be referred. So they have made changes in the guideline so that mother in the periphery can be given a IM injection and referred. And since dexamethasone was easily available in the community, dexamethasone was the preferred agent in the government setups. But both are equally efficacious. Both are dexamethasone should be given 6 mg 12 hourly for 4 doses. Betamethasone should be given 12 mg 24 hours for 2 doses. And when we give these doses, we call it as a complete course of steroid. And after the last dose, you have to wait for 24 hours for the efficacy of the steroids to start. And we know that both these steroids are equally efficacious. Mortality decreases by 22%, death decreases by 15%, and major thing that RDS decreases by 30%, moderate to severe decreases by 30%. Need for ventilation or CPAP decreases by 25%. More important, the brain-related injury, that is intraventricular hemorrhage, decreases by 42%. And necrotizing enterocolitis decreases by 50%. And even early onset sepsis also is reduced by using antenatal steroid. So because of these many advantages, what happened is over time, because of so many advantages, steroids became like it was used for every expected preterm delivery, and this led to misuse of steroids. And when every pregnant mother who was coming for any risk factor between 24 to 34 weeks was given steroid, this led to the misuse. And what happened? Because of this news, 53% of patients with preterm labor were undelivered 7 days after diagnosis, and 40% gave birth at term. So you can see that Many were unnecessarily given antenatal steroids. So when there was a risk, they were given steroid, but they were not delivering preterm. So the effect, what would have been the effect? If the baby delivers preterm, it is going to give all the benefits which are discussed. But if the baby is going to be steroid, receives antenatal steroid, but deliver at term, and this has shown to have adverse outcomes if they're delivered at term. So if the fetus receives steroids at 24 to 34 weeks, but is not delivered at that time, then it's going to have adverse effect on the baby in the long term, even if it delivered at term. So that is why now WHO has come out with new guidelines saying that expected steroid should be given only for expected delivery within the next 7 days and for gestation between 23 to 33 weeks of gestation. And we have to follow all the three things. All the three things should be there. That there should be preterm labor with cervical dilatation, which means the cervical dilatation should be at least 3 centimeters and cervix effacement should be more than 75%. Or there should be a premature rupture of membrane, that is rupture before the onset of labor, or there should be a bleeding antepartum hemorrhage or a pre-eclampsia with severe features like imminent eclampsia should be there for you to give steroid to the mother. So these guidelines have come to prevent the misuse so that the babies who are given steroids are delivered at that point of time within the 7 days, not later than 34 weeks. And these guidelines should be strictly followed so that the misuse and unnecessary adverse effects on the fetus can be avoided. So the second important prenatal thing should be if the mother is going to deliver preterm between 24 to 34 weeks, and preferably those mothers who are delivering less than 30 weeks should be referred to perinatal centers with experience in management of RDS. So, and this has shown dramatic decrease in death or major morbidities. It has shown to lower risk of severe IVH and has also shown to be lower incidence of CLD and PPD. In our own experience, both Naveen and myself, we remember that when we used to get outborn babies, our mortality rate on extreme preterms were very high. Now, when we see more of inborn babies and mothers delivering in our own centers, the outcomes of RDS has significantly improved. PDA, infections, these are very minimal if the babies are delivered in perinatal centers where RDS can be easily be managed. So if a VLBW baby is going to get delivered, it is better that the mother is referred rather than baby delivered and referred to a tertiary care center. There is good evidence that outcomes are improved, and then good experience that definitely outcomes are better if for inborn babies rather than outborn RDS babies. So what do we do at birth? And these are significant changes which have happened over the last decade. So at birth and the golden hour, so one important thing which has changed neonatology is delayed cord clamping. So now we say that if you should wait at least for 60 seconds for the cord clamping to occur across gestations. And if it's not possible and the baby is more than 28 weeks, we can do cord milking. Less than 28 weeks, we avoid cord milking because it is known to increase the risk of having IVH. So if the baby has respiratory distress, we should use TPs for resuscitation. And if the baby requires resuscitation, you should use a graded oxygen. So less than 28 weeks, you should use 30% oxygen. 28 to 30 weeks, 31 weeks, you should use 21 to 30% oxygen. And more than 32 weeks or 32 and above weeks, we have to use only room air for resuscitation. And if you should follow the SpO2 charts, and if the baby is not improving, you should gradually increase the FiO2 based on the saturation target for the first 8 to 10 minutes. If baby respiratory distress stabilizes with CPAP, and we need to use a CPAP of 6 centimeters and FiO2 should be less than 30%. And again, remember when we started CPAP, we used to say FiO2 of 50%, but now we would work on improving the lung, that is open the lung and then give FiO2. That is why work on pressure rather than oxygen in the delivery room or in the initial few hours, so that you should use less oxygen for opening of the lungs and for better air oxygen delivery. So delayed cord clamping, you can see if you don't delay, the cord is going to be having all the blood. But if you delay the cord clamping, the cord is going to look pale. Nearly 30 ml of, so 30 ml of the blood for 60 seconds, 30 ml of the blood from the placenta is going to come to the baby. And this is a very good volume for the babies who are very low birth weight babies. It will prevent blood transfusions. It will improve their overall outcomes. It will improve their neurological outcomes. It will decrease IVH. And all the neurological outcomes are better if you delay the cord clamping. And this has significantly shown better effects in all our babies also. So what is futuristic is intact cord resuscitation. Suppose baby is not breathing at birth. So baby comes out of the mother's womb and the baby is still connected to the mother's placenta, or the placenta is still connected. You do the resuscitation on the table and while the placental blood is flowing. So if you can do resuscitation like that, and some experiments have already shown that if by doing that intact cord resuscitation, that we are not clamping the cord, first you are opening the lungs while the blood is still flowing to the lungs. So if you do that, then you will have better oxygenation, better PaCO2s, and better cardiac output, and better delivery of oxygen to the brain. This is already shown in animal experiments. We have good things which have come up in our own country where people have used delivery room resuscitation, intact cord resuscitation have shown good outcome, and it is feasible now. So animal experiments have shown good outcomes, and human experiments also are in the pipeline to show that intact cord resuscitation is going to give good outcomes for especially babies who are going to require resuscitation at birth. So in that, with that background, Merck's TPs is going to be very useful. It has an inbuilt compressor, and it has you can titrate the flow, you can titrate the FiO2, you can titrate the pressure using this device, and it can be transportable. It is light. It has inbuilt battery for 4 to 6 hours. It can work, and you can use this device standalone without oxygen, 21% oxygen. You can use this device for CPAP as well as for TPs in the delivery room for intact cord resuscitation. If you connect oxygen from a cylinder, you can increase the FiO2 by increasing the input oxygen to this device. So you increase FiO2. If you want to increase FiO2, you need to increase the input oxygen or from the cylinders to this device so that FiO2 can be increased and FiO2 is displayed on this device. So I feel this device is going to replace all the TPSs in the labor rooms and during transport, because this has inbuilt compressor and you can transportable everywhere in the country. We can use this because many places we are using 100% oxygen for delivery of CPAP or TPs in the delivery room and during transport, and that is going not good for the small babies. So that is one of the biggest reasons for in our country having more ROP and more BPD in small babies, extreme low birth weight as well as very low birth weight babies. So I hope such devices will definitely be useful in improving the outcome of RDS, in preventing the adverse effect of RDS like BPD, and also in other outcomes related to the brain and the eyes. So coming to the golden agar, so at birth, you need to use a device which has inbuilt compressor, oxygen, delivery should be titrated, and the delayed cord clamping should be done at delivery. So in the golden hour after that, so what you need to do is caffeine should be used as early as possible. And babies who have respiratory distress, we should use CPAP, and we should try to go for early rescue surfactant. And surfactant can be Beractant or Poractant alpha. Beractant, if you're giving 100 dose, is 100 mg per kg. Poractant, if you're giving 200 mg per kg, is the dose, evidence-based dose. And the preferred method is LISA. Although there are a lot of studies which have shown that LISA is a good method, so I believe it is good, but the efficacy shown of LISA is mostly when compared to CPAP alone and not CPAP with surfactant. All the studies which have compared LISA with Ensure are actually comparing LISA with CPAP alone and not CPAP and surfactant. So LISA, I agree that LISA is good. It is doable. And if you use the correct method, it is good for the babies. But the efficacy is not because of the procedure, but efficacy is because of the procedure and surfactant given while the baby is spontaneous breathing with the CPAP in place. So laryngeal mask surfactant can be given for babies more than 1 kg. And now we have masks which are available for less than 2 kgs also. Masks are now available. So repeat doses can be used for persistent respiratory distress, especially if your FiO2 continues to be more than 40% and your CPAP requirement is more than 6 centimeters of pressure. So early use of surfactant, again, I said antenatal steroid, delivery room, tertiary care delivery, delayed cord clamping, intact resuscitation, resuscitation with blended oxygen, and now caffeine. Caffeine has revolutionized the care of neonatology because the CAP trial has shown that when you use caffeine as a routine in babies who are less than 30 weeks or less than 1250 grams, your outcomes increase across the board. It decreases the incidence of death by 10%. BPD decreases by 50%. BPD or death by 50%. IVH, PVL decrease by about 45 to 50%. ROP decreases by about 50%. So these are huge differences. So if you use early caffeine for all babies less than 32 weeks, 20 milligram per kg loading followed by 5 mg per kg per day from birth till 36 weeks PMA. For babies less than 32 weeks, you get all these good outcomes. So caffeine should be used as early as possible. The moment baby comes to the NICU, you should start giving a bolus dose of caffeine and CPAP and very early surfactant. So as far as early CPAP and early surfactant are called, if the baby has distress, you should start delivery room CPAP. And we prefer that all babies less than 32 weeks, 35 weeks, if they have respiratory distress in the labor room, we should start CPAP in the labor room, shift the baby on TPs. And after coming to the NICU, you switch over to bubble CPAP or any other CPAP. So it is called early rescue CPAP. Rescue means the babies who have distress are started on CPAP, and the babies who do not have distress, we don't start CPAP. That is prophylactic CPAP. Prophylactic CPAP is not advised, but early rescue CPAP is advised. The earlier you do, the better is outcome. And the reason for that is you should give CPAP before the lung fluid disappears. At birth, the lungs are filled with fluid. So that volume of the lung is good. As the lung fluid disappears, if the surfactant is not there, lungs collapse. And if the lungs collapse, it becomes very stiff and becomes difficult to open the lungs. So the earlier you give CPAP, before the lungs collapse, the efficacy is going to be better off. So that is why in places where you start delivery room CPAP, your need for ventilation, your need for surfactant will dramatically come down. So all of us should aim for delivery room CPAP, CPAP during transport, and bubble CPAP while the baby comes to the NICU. So early rescue CPAP should be started in the delivery room and switched over to bubble in the NICU. And all babies in the NICU should be started with CPAP if they have ASA score more than 3 and if they have distress. But babies less than 34 weeks, in the delivery room, we start CPAP if they have RD. Early rescue surfactant, again, giving surfactant before the lung fluid disappears, help in better dissemination and better coating of the lung with surfactant. In our own study, we have shown that if you give surfactant less than 2 hours before the FiO2 rises, your effects are significantly improved. From 30% need for ventilation, we could bring down the need for ventilation to 50%. One of my friends, Dr. Hemashri Kandaraju, has worked significantly in the year 2006 on this aspect and shown that by giving surfactant early in the NICU, you can decrease the need for ventilation. So if the baby is on CPAP and if he requires FiO2 more than 30%, the baby should be given surfactant using either Ensure or better will be Lisa method. And these babies, if they have RDS, especially less than 35 weeks, you can, even without X-ray, you can give surfactant. More than 35 weeks, you can get an X-ray and look for signs of RDS and then give surfactant. So this has shown decreased need for intubation, decreased need for ventilation, lesser BPD and lesser cost of care. So giving surfactant decreases the cost of care because it decreases ventilation, decreases the duration of hospitalization. So this is a wonderful chart which I've downloaded from the Pediatrics and Neonatology journal. So you can follow this. So you see, first 60 minutes is very important. So you start delivery room CPAP and verify pressure transmission by hearing the bubbles, by seeing the bubbles, ensure that the prongs are adequately paced. And again, Ram's cannula has definitely revolutionized care of CPAP. We use Rams in the labor room, we use Rams during transport, and we use Rams in the NICU also. And for extremely small babies, if you are not able to deliver pressure with Rams, you can use the mask, but Rams is simple to use and easy to titrate pressures and oxygen. So connect the pulse ox to the right hand within 1 to 5 minutes and insert an umbilical line within the first 30 minutes and test the sugars. At admission, you should check the temperature and sugars, and because that should be stabilized as early as possible, and give surfactant within the first half an hour if possible before the lung fluid disappears, and start the baby on aminovin. The first fluid should be amino acid, because the earlier you start amino acid, better will be the anabolism, better will be the weight gain, and better will be the outcomes of this baby. And again, the moment you start the line, you can give a caffeine bolus and start aminovin. Other drugs or sedations are scheduled later. We do not use sedation routinely, and we do not use antacids routinely. So place a transcutaneous blood catheter or the pulse oximeter, and next step, within 30 minutes or within 1 hour, try to get mother's own milk. The earlier you give the drop of colostrum to the baby, just coat the mouth of the baby with colostrum, you will be able to colonize the baby's mouth and baby's gut with the mother's flora and mother's gut, mother's microbiota, so that the babies can be salvaged from all the infections. Then came the lung ultrasound. Within the first 3 hours, you can do a lung ultrasound to predict the subsequent need for ventilation and surfactant need also. So this is what we are doing in our NICUs also. We have gone for more often than lung ultrasound than X-rays for making diagnosis of RDS and also for seeing for severity of RDS. So within the first hour, start CPAP, temperature management, sugar management, umbilical line, aminovin, caffeine, surfactant, and then mother's own milk. Coat the mother's milk on the baby's mouth. And within the first 1 hour, if you give mother's own milk and ask the mother to pump as frequently as possible in the first few days, your baby's outcome are going to be dramatic. So I feel the three major interventions which have improved the outcomes of premature babies are steroids, CPAP, and mother's own milk. Others are add-ons, surfactant and caffeine, but these are the three most important therapies as far as RDS is concerned. So lung ultrasound, yeah, I'm sure that many of you are using lung ultrasound. It has decreased the need for doing X-rays. So it's a useful predictor for CPAP failure and need for surfactant. It can actually diagnose the severity of RDS. And all that you need is just put your linear probe on the chest anteriorly, laterally, and posteriorly, and you will see how severe is the RDS. So how do you make out? Look at the pleural line, the movement of the pleural line, the thickness of the pleural line, and see whether these horizontal lines are there or not. If there are all the horizontal lines, there is no lung disease. Absence of horizontal line means there is lung disease. The vertical lines, the vertical shadows, or the confluent blue lines, B lines, this means there is a lung disease. It means there is lung is filled with fluid or there is atelectasis. So sometimes you can see the subpleural consolidation, which are very specific markers for severity of RDS. So you look for pleural thickening, you look for absence of A lines, you look for the type of B lines and the subpleural consolidation to grade for RDS. And we ourselves have looked at this grading of RDS, and we studied 192 babies. And when the median score is more than 7, the likelihood of that baby having need for surfactant or ventilation is about 40%. But if the score is less than 9, less than 7, you see that 95% chance that the baby will not require ventilation. So this is a very good predictor. Negative predictive value is always better, because if the lung score is less than 7, you can safely continue the baby on CPAP and surfactant, and you didn't have to think of shifting the baby to a place where ventilations are available. So I would suggest that use liberally, especially in places where you don't have a ventilator backup. So you can do the lung ultrasound anteriorly, laterally, and posteriorly, and look for this. The presence of A line is the A pattern, 0 score. The B lines you can see here, vertical B lines, and there are some air shadows which are there. The black lines vertical, that means it's only score 1, and score 2 is when all the B lines merge. There is no there is no black vertical lines, only there is something like ground glass appearance is there. Hepatization is score 2, and score 3 is subpleural consolidation. Under the pleura you will see some breakdown points, and that you have, it is a sign of severe RDS. So you add up all this score on the anteriorly, on the laterally, and posteriorly. If you got a score more than 7, you know that baby may require surfactant, but less than 7, you know that baby will not require subsequent ventilation. So subsequently, after the golden hour, so in the NICU stay, continue to use CPAP for RDS, extubate the baby to CPAP as early as possible, and if the baby requires failed CPAP, go for synchronized NIV. And I said NAVA is very soon going to come into all the NICUs, because synchronization will definitely improve the outcomes of NIVs, and it will become as stable as CPAP or as easy as CPAP with the addition of RAM cannula to the NIV devices. HFNC is useful as a primary mode or as a backup mode, especially if you have backup NIV or CPAP or backup ventilation is available. The failure rate of HFNC as a primary mode is almost 3 to 4 times higher compared to CPAP or NIV. So as a primary mode, I would discourage, but if you're using, have a backup CPAP or NIV. And always go for gentle ventilation and volume targeted ventilation to ensure that you don't land this RDS to BPD. And all our efforts are to prevent BPD in these small babies. So, and one more very important addition to neonatology or RDS is video laryngoscopy. And I know Naveen works a lot on intubations and extubation failures. His one pet area is airway malformations and airway management. And video laryngoscopy, at least in the Western world, has shown that using video laryngoscopy, your success rate of intubation increases, your damage to the airway decreases, and your extubation failures decreases. So you can put the baby more often on CPAP rather than on ventilation. So to prevent BPD, RDS becoming BPD, you need to learn good ventilation strategies. Volume target ventilation is what we should do for all our babies who are having RDS. And we should extubate them early to CPAP, HFNC or NIV, and preferably within the first 7 days. And tidal volume, you can target 4 to 7. Avoid high tidal volume in the first few days because volume trauma is the worst trauma which you can happen to the premature babies. And use short TIs, rates of 40 to 60 per minute, and pressures, mediocre pressures, and pressure of 5 to 6, CPAP of 5 to 6. Your target PO2 should be between 40 to 60, and PCO2 should be between 45 to 50 mm of mercury. So there are nearly 20 trials, 16 parallel trials, 4 crossover trials. So all have shown no difference in death, but they've decreased the next BPD at 36 weeks by about 27%. Has decreased the rates of hypocarbia, meaning it has improved the brain outcomes, and your grade IVH, grade 3, grade 5 which have decreased by 50%, and it has also decreased the combined IVH and PVL by about 50%. So volume targeted ventilation should be the mode of ventilation for babies who require ventilation. So NAVA is going to be the futuristic non-invasive ventilation if a baby fails CPAP, and this works well better because what happens is in NAVA, you have an electrode at the esophagus. The moment baby makes an effort, the diaphragm gets a signal from the brain that wants to take a breath, and this electrical signal is picked by the electrode, and that time the pressure is given to the nose. So the PIP is given, or the NAVA PIP or the non-invasive PIP is given when the diaphragm starts to contract, so that there is an excellent synchrony for the baby. And if you're using NIV, you can see here the electrical current in the diaphragm is called eddy current. So you can see that the moment the current in the diaphragm starts, that time the pressure is given by the NAVA machine, and proportional to the current, the pressures are given to the nose. So it is like based on the baby's efforts, based on the baby's needs, the pressures are given. So if the baby makes more efforts, more pressures are given to the lungs. So if the baby needs more pressure, automatically the machine detects that the baby needs more pressure, and more pressures are given, and the pressures are given only when the electrical activity of the diaphragm is detected. So there is an excellent synchrony, and the moment electrical activity decreases, the pressures also decrease. So there is inspiratory synchrony, there is expiratory synchrony, and there is proportionality of the pressure which is given to the baby based on the electrical current. And you can see NAVA can be done on ventilation, NAVA can be done on non-invasive ventilation, and if you don't have to ventilate also, you can use NAVA to see the diaphragmatic activity of the baby or how severe the baby's respiratory distress is. The more the activity, the more severe the respiratory distress. Less the activity of the diaphragm electrical activity, less severe is the respiratory distress. So it can be used in multiple methods for assessing severity, for synchronization of NIV, and also for ventilator synchronization. I feel this is going to be a very useful technique for synchronization, also for proportional assist NIV mode of ventilations. So to prevent BPD, RDS going into BPD, we would suggest the best golden hour management, synchronized TPs, and using proportional oxygen, gentle ventilation, early CPAP, early surfactant before the lung fluid disappears, volume targeted ventilation if the baby requires ventilation, focus on early nutrition, early parental nutrition. If you're giving fluids, amino acid should be the first fluid. Concentrate on giving mother's own milk. All our babies less than 1 kg by 7 or 8 days, they should be on full enteral feeds. If they're not on enteral feeds by 7-8 days, something is wrong. We can work on our mom's quality improvement project so that every baby in the NICU should be on mother's own milk and should not be an IV fluid, even if the baby is on CPAP or on ventilation. And infections are the biggest threat, and the best way to conquer infections is by cutting down the IV fluids and increasing the concentration of mom which we give to the babies. So surfactant with budesonide, I feel this is another important intervention which is going to change preventing BPD in babies with RDS. So especially less than 26 or 25 weeks babies. Nutrition, early aggressive parental nutrition, you should aim for giving 3.5 to 4.5 gram of protein, calorie between 125 to 140 kilocalories, colostrum coating of mouth within first 1 hour, and subsequently first 2 days early and aggressive pumping. And you should increase the use of mom, because mom has a dose dependent effect on all the important outcomes of the preterm, more so of the RDS as well as ROP and brain related outcomes. The more quantity of milk you give, the lesser will be the morbidities of the baby, and we should aim to reach full enteral feeds by 7 or 8 days with mom. So to get the best mom, you should have adequate number of breast pumps in the unit. You should have champions. There should be a good lactation nurse. All the nurses should be dedicated to ensure that they're giving enteral feeds and mostly of mom. And you should have a good policy of mother's own milk for the NICU. And you should have a dashboard which reflects how many babies in your NICU are VLBWs and who are on full mom. So just to summarize about the recent advances in the management of RDS, history of RDS is very dramatic and evolving across the globe, and more so in our country. There has to be significant breakthrough interventions, mainly CPAP, surfactant, antenatal steroid, which are called the trio of RDS. And I feel caffeine, mom, and volume targeted ventilation have significantly improved the outcomes of RDS. And future, I think, is going to be intact cord resuscitation for those babies who require resuscitation. Lung ultrasound will replace X-rays, and nebulized surfactant will replace all other modes of surfactant. And budesonide addition for extreme preterm babies may help in preventing RDS, especially combination of budesonide with surfactant. And I feel NAVA will become a general mode of therapy after CPAP for babies who fail CPAP. So thank you, and I'm open for questions.
Thank you, Srini. The most important question somebody has posted is, can they get a presentation? So
yeah,
it's
it is
understandable
recorded.
that they really wanted. Srini, before I open to panelists, one question that we are facing as challenges. I know we have done some work on this. It's a thesis very long back. It's a baby is there who is say 1 kilo baby breathing well. We are put on CPAP. We are nearing 2 hours of life. Baby is still having some distress, maybe some 30% oxygen, and a very difficult decision whether to tube him and give surfactant or continue on CPAP for a few hours more. Are we missing the window? How do we take a decision?
So I think now you have very good tools. Suppose you have a doubt, lung ultrasound is going to help you. As I told you that if your score is 7 or more, you just need to put the probe on the anteriorly, lateral and posterior, take the freeze the films, 3 films, you get the score. If it's 7, you know that baby is likely to worsen and then may require surfactant. If not now, little later. So if you don't have, I would always err on the side of giving surfactant rather than continuing the baby on CPAP, because I feel in our country, ventilation is still a difficult task. So even if you give 1 or 2 extra dose of surfactant and avoid one ventilation, I feel it is worth it.
There was a question on prophylactic CPAP or prophylactic caffeine or early caffeine in the chat box.
So the work is very significant work has come from Barbara Smith and the group, and many other people have taken over after it, that the earlier you give CPAP, especially caffeine for less than 30 weeks, in less than 30 weeks, you can think of as a routine prophylactic caffeine. But more than 30 weeks, you can give caffeine if the baby is on CPAP or another mode of respiratory support. 32 weeks and above, we try to avoid caffeine as a routine therapy. The other method is less than 1250 grams, give as a prophylactic. More than 1250 grams, you can give only SOS when the baby has apnea or requiring respiratory support.
There's a question on early biomarkers for BPD prediction.
So I'm not very sure of the biomarkers. Maybe you can take that question. I'm not very sure how these biomarkers are going to help. Yes, but budesonide is one thing which has come up, because I think people have looked at biomarkers and felt that babies who have increased biomarkers are the babies likely to go for BPD. And I'm sure the question is aimed at which baby should be given surfactant with budesonide for prevention of RDS, for prevention of BPD.
Although it's a little lateral question, but there are some questions on details of ultrasound and whether you need to do it on different areas and how do you score them.
So I've shown the picture. I think the slide can be shared with all the people. So it has just, you take a linear probe, any linear probe, put it on anteriorly, put in laterally, and put it posteriorly, and you can have 0, 1, 2, 3. 0 is A lines, 1 is B lines, 2 is confluent or hepatization, and 3 is subpleural consolidation. So all the three areas you give 0, 1, 2, 3 score, add up the score, total score in one part of the lung, it's more than 7. You know that it is a severe RDS, may require ventilation in future. So the earlier you do, the better is the prediction. So do it in the first 2-3 hours so that you can avoid ventilation 6 hours later.
Somebody wants to know, does Srinivas use budesonide because that's what they want to do?
No, we don't use budesonide because again, whatever trials of budesonide, they're talking about less than 26 weeks. So my experience of less than 26 weeks is minimal. So I've not ventured into using budesonide, but I'm sure many of you, many of the youngsters are managing babies 750, less than 750 grams and less than 26 weeks. And those are the babies, I think, who are candidates for this anti-inflammatory action of budesonide.
Any question is on INO in extreme preterm babies.
So again, if you ask me, evidence is not very clear, but we know that 30% of babies with RDS or who are likely to go to BPD, 30% of them have a pulmonary hypertension. And babies who have pulmonary hypertension are the babies who are likely to become BPD at 36 weeks. So there are good number of studies saying that pulmonary hypertension is universally there in babies who are having likely to become BPD. But how do we treat the pulmonary hypertension? Should be INO? Should it be some other therapy? The evidence is not clear. So, but there are some units which are using low dose INO for treatment of BPD, especially if they are able to pick up PPHN by 1 week after birth. And here the ppm is 1 unit. 1 ppm per 1 ppm is what we use. So we are not using INO at all for BPD babies.
Srinivas, we have two other senior colleagues in the audience, and one is Vishal and other is Prakash. Vishal has a question on technical aspect on Ram's cannula, and if it is not having an expiratory limb which is allowing the pressure to build up, how does it happen?
So that's a very wonderful question, and I'm a fan of Ram's cannula, but I know the problems of Ram's cannula. So as the question is rightly put up, so Ram's cannula, what it does is the cannula is like this. It goes behind, the air moves across the Ram's cannula. The flow is across the Ram's cannula, and the flow coming to the baby is coming in both the sides of the prongs. So you should have some amount of leak in Ram's cannula. Never occlude the nose completely when you are using Ram's cannula for CPAP or for NIV. The cannula should fit only 80% of the interface or the nose. There should always be leak. Always have a feeding tube in place, and the tip of the tube should be above the level of the tummy so that there are no gastric perforations with Ram's cannula. So first tip is you should use Ram's cannula only 80% of the coverage. There should be leak when you're using Ram's cannula. Do not use cannulate for fixing the Ram's cannula. Ram's cannula can be easily fixed with a mustache on the sides, and don't use cannulate and completely occlude the nose with Ram's cannula. That's the first point. Second is, yes, the delivery of pressure is 1 centimeter less than what you get with CPAP with mask or with other interfaces like Hudson prongs. So if you want to give 5, should give 6. If you want to give 6, you can go up to 7 pressure with whenever you're using Ram's cannula. So little higher pressure and ensuring that it is not occluding the nose completely is what precaution you have to take when you're using Ram's cannula. But Ram's cannula can be used for all babies more than 1 kg in the labor room, during transport, and also during NICU care.
Dr. Prakash, any comments? Prakash is here. Prakash Manikot. I don't know whether I had to unmute him. Let me just check.
So if you want, we can unmute Mr. Prakash and he can be on the line if you want.
Yeah, let's just see.
Please unmute Prakash, sir.
Sure. Will you right away, sir?
Yeah, I think he's unmuted now.
Hello.
Yeah, your voice is echoing, sir.
Yeah.
Now it's all right. Yes.
Greetings from Muscat, Dr. Murki. Very comprehensive and well-crafted presentation. I think echo is there. Before giving the second dose for
So if
beginners,
you only have one device, you can refer to like.
is my audio disturbing?
Yes, sir. I think
logging with two devices.
two audios are there. You switch off one of them.
You have joined from two devices. One device you have to put it on mute actually.
I'm sorry.
Srini, while Prakash's question comes in, a lot of units are now using HFNC prongs, device, and giving NIV. I think I know your answer, but still.
I think the purpose of HFNC is very different from comparing to CPAP or NIV. Never use the HFNC prongs. The HFNC prongs have to be as least size as possible. They should not occupy 50% of the nose diameter. If they occupy only 30%, it's good. And the prongs of HFNC are very tapered. They go tapered into the nose. They give a flow of oxygen, which is working on diffusion. So always think that HFNC is for diffusion of gases, where you are giving very high flows and some flows have to come out from the nostrils. If you don't do that, you will land up with causing pneumothorax as well as lung injury and gastric rupture. So never use the HFNC prongs for delivering CPAP or for NIV, and never use the CPAP or NIV prongs for delivering HFNC. There is no way you can use the same circuit, but if you're using, say, fission Packel circuit, you replace with OptiFlow for giving HFNC.
And was your comments on low flow oxygen therapy?
I think many babies who are coming out of CPAP, especially those less than 1 kg, I would prefer continuing on CPAP for some time. They require pressure or oxygen. So you keep them on CPAP till the lung growth happens and till the baby is out of oxygen and some pressure support. But more than 1 kg, low flow oxygen is used only for 1 liter or 2 liters of oxygen, sometimes even for weeks, but that is unnecessarily prolong the duration of respiratory support. So if you are able to use low flow versus CPAP, I would prefer CPAP. But if you don't want to use CPAP and give breastfeeding or spoon feeding, low flow oxygen also can be used, but it is used as humidified oxygen and not as a free flow oxygen.
I think Prakash hasn't come in, but another important question is, Srini, 35 weeks or 34 weeks pregnancy and antenatal steroids for prevention of RDS.
So I'm not a big advocate of steroid for late preterm or for term babies, and I don't think that because already you've seen how much misuse has happened even for the babies where we have to give it. Between 24 to 34 weeks only, we are saying 50% are getting added unnecessary steroid. So if you open it for late preterm or term babies, many babies may unnecessarily get steroids, and it's not a good therapy without indication. So at least the UK guidelines say that they can be given for late preterm and elective C-section, but I'm not a proponent of that. And I don't think the evidence is strong enough to give for late preterm and term babies. So you have to be very strict guideline for giving those babies, much more stricter than what you can go for 23 to 33 weeks.
One commercial question, Srini.
Yes.
How can they buy more CPAP?
So Merck CPAP is easily available. It is marketed by Electrogenics, and I would prefer, if not Merck's, use any other TPs which has inbuilt compressor. You should be able to titrate the FiO2, and never give CPAP with a humidifier, because if you are going to buy any of these devices with inbuilt compressor, buy a humidifier, because humidifier is a must for delivering CPAP or NIV. So Electrogenics, you can easily Google, and it gives you at the CPAP, Merck CPAP with humidifier will come about as 2 lakhs rupees, and only for Merck CPAP you get about 80,000 to 90,000 rupees. You don't need anything else because it has inbuilt compressor and inbuilt FiO2 monitoring. And if you can use it with cylinder oxygen, and you have to use only cylinder oxygen because you need to input only low flow oxygen to titrate the FiO2.
Prakash has a very valuable comment, but you can probably expand on that. That before giving second dose of surfactant, you need to look out for things that you might have done wrong, like a small pneumothorax or collapse of a lung, before you just jump and give one more dose of surfactant.
So I think whether it is surfactant or whether it is CPAP failure, I always tell that look for the bubbles, hear for the bubbles, ensure that the bubbling is heard symmetrically in the both the axilla, and you should ensure the pressure is reaching the lung. Always concentrate on pressure rather than FiO2. And maybe you should pick up pneumothorax. Maybe you should look at humidification. Maybe you should feed the baby, ensure that the baby is comfortable, nest the baby, cocoon the baby, switch off the lights. So many things we do during that 1 hour, which can cause a lot of pain for the baby. And we should ensure good developmental supportive care for the babies before we say that baby has not either CPAP or surfactant or not worked for the baby.
One question is to Ravi. Ravi, how long are the chat lines open? Because you are giving them some gift books. So how long they can still put something random messages at least to get a prize?
So at least, what I expect is that you give us some feedback on the form that I've circulated, so that we get to know that, and the response. So I think that the good response that we get, I think definitely we can provide some access to the book for sure.
Okay. I think one more question has come. Let me just see.
No, prophylactic CPAP cannot be used for all babies. So prophylactic CPAP, I'm not advocate of prophylactic CPAP. I recommend early rescue CPAP. CPAP should be given only if the baby has signs of respiratory distress, not for babies who don't have distress, whether it is labor room or in the NICU also.
In all our ventilation workshops, we always try to conclude with a very important panel discussion session. A lot of people are doing wonderful work, like you said, setting up units in places where nobody is taking neonatology. Other than CPAP device, surfactant, ventilation, maybe 8 or 9, 10 things, whatever we want to tell them, which will change their outcomes and make it much better.
So I think the biggest challenge and the biggest thing which we need to learn in our country is getting the babies out of IV fluids and avoiding antibiotic usage. And this you can do it only by concentrating on mother's own milk right from the word go. Ensure that every mother has access for her baby 24/7. The mother should come and spend time in the NICU, and the mother should talk to the baby. Mother should handle the baby. Mother should be involved in baby care. She should pump in the NICU, and she should be able to give milk. By third, fourth day, every mother produces more milk than what the baby needs. So, and this is again which work in outborn babies. We could do it in outborn babies. By third, fourth day, the baby's mothers have more milk than what the baby requires. So if you concentrate on mother's own milk, your infections are out, your IV fluids are out, your central lines are out, and your antibiotic need is out. So ventilation is very easy if you can put the baby on feeds, and then whatever mode of ventilation, whether it's CPAP, NIV, HFOV, all can be done with full enteral feeds. So I think in India, at least, we should concentrate on preventing infections and focusing on mother's own milk.
Your personal take on Lisa, Srinivas?
So I feel the evidence is not the correct evidence, because I am not against Lisa, but saying that Lisa will improve BPD or eliminate BPD is wrong. So Lisa has always been compared with isolate CPAP. So in most of the studies of Lisa, what they've done is they've given surfactant, CPAP using Lisa method. In the other group, they've given CPAP, and they've given surfactant only when the baby is requiring ventilation. So they're not actually comparing CPAP with Lisa with Ensure. So, and the studies which have compared Lisa with Ensure, there are minuscule studies, and these studies have not shown major difference between Lisa and Ensure. So, but technique wise, Lisa is a challenging task, but I'm sure that most of the neonatologists in our country will be able to do it very easily. It is just an art which all of us need to, or a skill which we need to learn. And if you learn the skill, I think Lisa should be promoted. But you know that Lisa should be done with a Lisa cath and not with the feeding tubes. Because using Lisa cath and ensuring that Lisa cath is kept in the refrigerator for it to become stiff, and after going it inside, while the CPAP is going, you should give surfactant while CPAP is going on, because the lung should be inflated while the surfactant is going into the airway. So that is how the best efficacy of Lisa is going to be there. And many people in our country, wonderful work has been done by Tapas from Calcutta, where he has shown significantly that Lisa is doable, and it has shown significant benefit for the babies.
Ravi, can you unmute Vishal? He is another passionate worker with a lot of research and clinical work, a lot of contributions to CPG guidelines. And meanwhile,
Sure.
Srinivas can take the question on doses
Sir,
of
what full
caffeine.
name?
How high?
Vishal Vishnu Tiwari.
Vishal Tiwari, yeah. And Srinivas on dosing caffeine, higher doses of caffeine.
So basically, caffeine is actually the caffeine citrate of 10 mg per kg loading followed by 5 mg per kg caffeine citrate. Once daily is the recommended dose from the caffeine trial. But those babies who are having recurrent apneas, even on this maintenance dose, can go up to slightly higher dose. But saying that 8 and 10 routinely is not an advocated. And Naveen has done a wonderful work on caffeine, and he says that more than 32 weeks, you can give a caffeine for a week and stop it, because those babies don't require prolonged duration of caffeine. They can easily be stopped on after a week of caffeine. You can stop for bigger babies. Is that true, Naveen? Isn't it?
Yeah, for 29 weeks, if they didn't have severe RDS in the first 48 hours, only 3% recurrence rate, but less than 29 weeks, 30% recurrence rate. So if you're less than 29 weeks of severe RDS in the first 2 days, then you need to continue till 34 weeks. But like you said, bigger babies or less RDS at start, they succeeded well most of the time. Vishal, over to you, please.
Sir, firstly, thank you for this excellent talk and this, a revision of sorts for many of us. I have two questions and a small suggestion to give, sir. You can give your comments on that. One, I have noted that and been implementing for the past few years, a very good control of thermoregulation. So initially I was hesitant about this thing because I thought it has a commercial intent to it. But later on, I have become a big fan of it, and that is the use of NeoHelp, the plastic bags that come, which are available nowadays. So delivering babies inside those bags, and because my clientele is not able to replace them very regularly, we keep these babies for longer than recommended inside those bags with the baby's diaper on. So this thermoregulation dramatically affects the oxygen requirement. And even extremely low birth weight babies, they come out through Lisa. And I thought maybe this is contributing in some great measure. So that was my first point, sir. And secondly,
sorry, Vishal, just to add on to that, I agree with you completely that thermoregulation is a huge challenge. And in our own experience, I think incubator use has significantly improved in extreme preterm babies. And I feel extreme preterm babies, when you use good humidification and in an incubator, at least for the first 1 week, the outcomes are definitely better. And I have seen some innovations on incubator or humidification. So my friend of Ashish Mehta from Ahmedabad, what he does is, so he does the care in a radiant warmer. A cling wrap is used to cover the radiant warmer, and under the cling wrap, you run a humidified air, 21% air under the cling wrap, so the baby is warm and humidified while you're continuing the radiant warmer. So people have innovated in multiple ways to take care of small babies and making it very cost effective. So evaporative losses can be easily be prevented. The other thing, as you rightly pointed out, is instead of bags, some of us use the cling wrap itself. We wrap the baby on the cling wrap right in the delivery room, and we continue to keep it in the NICU till the baby wants to come out of it. So only in the areas where you have to put a umbilical line, those areas we open up, but the baby is on cling wrap for 2-3 days after birth without wiping. So evaporative losses dramatically come down, and it definitely improves the outcomes of extreme preterms. Over to
absolutely, you, sir. And absolutely, sir. Totally agree. There's another problem which I have noted that is pertaining to rapidly feeding babies. So in my initial years, we were trained to believe in minimal enteral nutrition and thereafter gradually increase by not more than 10 to 15 mLs per kg per day. But if you want a VLBW to reach full enteral feeds by day 7, day 8, your feed increments are not going to be less than 30 to 35 mLs per kg per day. In that case, sir, feed intolerance becomes a bugbear sometimes. And is there something we can do? Because sometimes units may not have adequate monitoring in terms of highly trained nurses who are going to monitor the baby's abdomen through the night. So it has happened that, a baby was stable, was tolerating his feeds well for the first 72 to 96 hours. And thereafter, over the night, the continued higher volume of enteral feeding created a uh, picture of feed intolerance or even maybe bordering NEC. So, your comments on that, sir?
So I think excellent work has come out from multiple units in the country. And if you talk to Sushma or if you talk to people from PGI and also Ashwini, I have gone to Dr. Ashwini's unit in Ludhiana and all babies were on enteral feeds, irrespective of the weight and gestation. Word from the go. Many babies were not even on a cannula, but these babies were on CPAP or NIV. The crux is to put them on mom. So how you get the mom is very important rather than formula feeds. If you can get mother's own milk or if you can get donor milk or if you have a good milk bank, I think some of these problems can be easily be addressed. So the fear of NEC is actually what is killing all of us because many of our babies die of infection and infection related morbidities rather than due to NEC. So I think it is doable. Yes, there are a small number of babies who are extreme preterms who are AEDF, READF babies. Those babies definitely it is not going to be easy task, but they need not go for like something like ADAPT trial, 5 days of MPO. They can be started on trophic feeds and then you can progress on the feeds. 2 ml 4 hourly initially, then 2 ml 2 hourly, and then 3 ml 2 hourly, and then 4 ml 2 hourly. Like that, by 6-7 days, you can come up with 7 to 8 ml feed 2 hourly, which is quite a volume for less than 1 kg babies.
Right. Thank you, sir. Thank you for that.
The sessions would never close, but one question before we ask Ravi whether we are due to close. When is the next session Srinivas is teaching in person ventilation where they can come and learn?
So, so now we are, all of you can fly to Kanpur. So 18, 19, 20, we are doing a ventilation workshop in Kanpur. And maybe somewhere in May, June, we will have one session in Hyderabad and I'll ask my good friend Naveen to join us. So that will be maybe May, June, Naveen. Block some date, 3 days.
Dr. Murki, if you suggest, sir, we can also live feed the session, like
Yeah, you can do that. Can do that. Yes, thank you.
Yes, sir.
Ravi, it's over to you. If there are other questions, people can still put in the chat box. Otherwise, Ravi will close the session.
Sure. Thank you, sir. And Dr. Murki, I think thank you so much, Dr. Naveen. Thank you so much for being part of this session. I think it's a very, very well attended session since many sessions that we are having nowadays. It's a very, very to the topic and very good response that we have got. Good participation from the people. And as Wolters Kluwer, we keep on bringing such medical health series webinars to our audiences and always request our audiences to be a part of these sessions. Very, very interesting sessions from the forum authors and the delegate in the fraternity. Also, I request all the students, all the attendees to please fill up your feedback form. Where feedback really help us to improvise our sessions in the future. And we'll keep on coming back with more such sessions, maybe more sessions from Dr. Murki itself and with the help of Dr. Naveen itself. Thank you so much for joining in today. If you have any other feedback and all, please write back to us. I'll post my email ID to the chat box so we can discuss later on for sure.
Ravi, there is a semi-commercial comment I'm going to make that
Sure,
there
sir.
are many young people in this group. And when we were doing the second edition, we included everyone who gave a comment on the first edition pointing to errors we made in the book. And they were all part of the second book because we felt that they were genuine people who wanted the book to get better. So all the people who are in this group and other friends, please find mistakes in our second edition because we will help in making a better third edition. And I promise that each one of you would be contributors in that edition. And this is our country's book. It is not my book or Wolters' book. We have to get beyond, like Srinivas always does, get beyond just being a fan of some other country, find your solutions for your own country. So please find wherever we have made mistakes, wherever things need to be majorly updated, just send a mail to us and you will be contributors in the next edition. That will be better than just getting a free copy of the ebook. Srinivas, your comments before we close.
Yeah, thank you. And I think Klohati has definitely improved, Indianized after Naveen has taken as editor. So we all love having a copy of Klohati, and then students also enjoying the new Klohati. As you rightly pointed out, that we need to find solution for our problems. And I find that our problems are very peculiar, like what Vishal said. We need to find solutions for everything. There is a solution. And you move across the country, you will find a lot of solutions. And I'm sure all this audience here are all going to find solution for their babies. So thank you everybody.
Thank you so much. One whole evening has been given to us and I'm sure everyone enjoyed it. Thank you so much, dear.
Thank you so much, sir. Thanks to all the speaker, Dr. Naveen Jain and Dr. Murki, as well as our audiences. Thank you so much.
Thank you,
Thank
Ravi.
you.
Bye-bye. Good night to you all.